Today, it's my absolute honour to introduce and welcome Professor Suzanne Garland, my original research mentor and PhD supervisor. There's very few who I admire more. Professor Suzanne Garland is internationally recognised as a clinical microbiologist and sexual health physician. She has particular expertise in infectious diseases related to reproductive health and the neonate. Her undergraduate degree was at the University of Melbourne, and her postgraduate training was in the UK public health system and at Harvard University. Professor Garland has been a leader in patient self-collected sampling using molecular techniques, PCR, for diagnosis of reproductive tract infections, predating diagnostic commercial assays. She has published extensively on the clinical epidemiology of sexually transmitted infections in Australia. She led phase 3 trials of the prophylactic HPV vaccines, findings from which were instrumental in the Australian government adopting a national immunisation program. Professor Garland led studies on genoprevalence of HPV in Australian women prior to introduction of the HPV vaccine, which has provided important baseline data from which post-vaccination effectiveness and impact are being defined. She's a regular advisor to the World Health Organization and has published in more than 650 peer-reviewed journals. In 2018, she was awarded the prestigious Officer of the Order of Australia, AO, and was elected Vice President of the International Papillomavirus Society, which was celebrated worldwide. Please help me warmly welcome Suzanne as she shares with us how Australia will likely become the first country to effectively eliminate cervical cancer. Thank you.
Well, thank you for that lovely introduction, Yasmin. And I guess as one gets older, it's lovely to see that you've got PhD students introducing you and having you work. So when I was actually invited to come here today and give a talk, I thought, what should I talk about? And we have done, as you heard from Yasmin, a lot of work on HPV and cervix cancer. So I thought I would basically choose this topic: can it be eliminated? What I thought too, given that the audience will probably be diverse, tell you a little bit about HPV or human papillomavirus, a little bit about its natural history, vaccination that we've had here in Australia. What do we really mean by elimination? You know, bearing in mind that we're talking about a very different virus to the traditional acute infectious diseases. How do we achieve this goal? Predictions and challenges, what modelling is telling us, what about surveillance, and then I'll finish off with some work that our group is doing in an MRC-funded Ethiopian and Indian program. So just to start with the burden of disease, if you look, this is the latest Globocan data, and you can see that cervix cancer is number 4 in the world amongst cancers in women, both in incidence as well as mortality. If you look worldwide, it's almost 600 new cases of cervix cancer each year, with just over 311,000 deaths. These are probably underestimates, but they're WHO figures. If we look, we're not just talking about cervix cancer here. There are other HPV-related cancers, and if you look globally, 5% of all cancers are caused by HPV. If you look at the incidence rates on the world map, the darker the colours, the higher the incidence. And you can see within our region, you know, obviously Australia is quite low in incidence figures, but within our region above us in Asia Pacific, almost half the cases in the world actually occur in our region. And again, if you look at the dark colours, it's the underserved, the less developed regions of the world where the highest rates are. And really the reason we have low rates is because of the intervention that's occurred through our very effective screening programs. and I'll come back to that later. Again, the mortality figures, so women who are diagnosed in the less developed regions die with the cancer. So I'm going to mention something about the HPV story because I think Australia has a bit to be very proud of. For those of you who were taught by people like Colin Laverty, he actually, way back in the 1980s, 70s, was actually one of the first people to actually see HPV in lesions. These were lesions in the cervix, and this is one of his electron micrographs. This was at a stage when people didn't really believe it was a viral infection. So this is the native virus, and then it was some years later when Jean Zhu, scientists working with Ian Fraser, and Ian Fraser, of course, actually then found these, which are called viral-like particles, which look very similar to the native virus. And that really became the basis on which we have our prophylactic vaccines now. And of course, linking HPV with cancer was Harold Zerhausen, who received the Nobel Prize for Physiology and Medicine in 2008. So it's a nice story, because what I'm going to show you really is not only have we, in my career, seen the proof that a virus causes cancer, but we've had the vaccines, which have been really effective. They've been rolled out as public health programs, and now we're seeing elimination or reduction in the diseases it causes. So what about the virus? It's a small virus, it's a DNA virus, it's not enveloped, and it has, as you can see here, the rosette. These are what's called the L1 protein, and they form these nice little rosettes, and that's what is really the basis of the immunity that we see through the vaccination, because all we use is the L1 protein. So again, taking a step back and thinking about the virus itself, there's many types of the HPV virus. They can't be grown in the traditional sense of culture in the lab. Everything's been picked up by molecular biology, so it's been a coup for them. Most of the infections are actually transient, common, and asymptomatic, and yet if you look at populations, about 80% of people get infected in their lifetime, so it's very common. It's the oncogenic types or the low-risk types that are specifically infecting the anogenital tract are sexually transmitted. What we mean by that is skin-to-skin or mucosa-to-mucosa transmission. So I think it's not like your traditional sexually transmitted infection, and it's really important that we destigmatize HPV because most people will get it. That becomes important in talking to patients about the infection. Latency is definitely recognized and probably happens in around 5 to 10% of cases. It's persistent infection with the oncogenic types that's a prerequisite for getting cancer and for actually causing the precursor lesions, the SIN3, or cervical intraepithelial neoplasia, grade 3. And if you look at cancers, you'll find that about 99% will have HPV DNA in them. If we look at the genotypes, there's probably a couple of hundred genotypes now being sequenced, but specifically with an affinity in the anogenital tract, it's around 30 to 40. And the high-risk types are the ones that cause the cancer. But if we look specifically at 16 and 18, these seem to be more oncogenic than other types. And you'll find, looking at cancers worldwide, 70% consistently have 16 and 18. And then after that, 31, 33, 45, 52, 58. The low-risk types largely cause benign lesions, although, you know, this is all about relative risk. And in fact, with 6 and 11, we have found some in anal cancers, and that's using laser microdissection. So certainly the low-risk types uncommonly can cause cancers. And if you look at, this is worldwide data, and you can see here the enrichment for disease with the 16 and 18. So if you look at the blue, 20% of the low-grade lesions, or SIN, what we used to call SIN1, which is really just the viral cytopathic effect of HPV. And it's really when you get to high-grade lesions, or the SIN3 is probably the precursor lesion, true precursor, you can see how the enrichment for the 16-18 is there. And of course, in cancers, 61%, 70%, depending on what study, but that consistent 16-18, 70%. So HPV is different from a lot of other viral infections in that there's a very long incubation period. And we know some of this from returned soldiers from the Korean War who were infected over there, came back, and then infected their partners. So that's how the incubation periods were pretty much worked out. And then lesions being seen in wives of men who may have themselves been asymptomatic or had lesions. And you can see here in this cartoon, maybe I'll use this. Oops. I'll use the mouse. There is an immune response, but it's very, very slow. So very different to a lot of other infectious diseases. And in fact, seroconversion can take many, many months. And even if you've got an antibody response, you can still have DNA detected, as you can see down here, but still persistent infection or disease. And whereas in those who eradicate the DNA with a natural immune response are protected or partially protected. Now I was going to show you, if we can, an easier way to look at the infection is in a little video here. Thank you very much. So HPV basically infects squamous epithelium. It normally just lies on the top. It doesn't cause any cytopathic effect unless you have a microabrasion, as you've got here. Then the virus actually comes down here, and you can see in the top right-hand corner the gene expression for E6, E7 happening low down around the basal cells and suprabasal cells. And then as the virus goes up through the differentiated epithelium, then you have the other genes expressed, such as the L1, and then you get active viral replication right through. Now, with, as I said, SIN1 is really just the cytopathic effect of the viral infection. SIN2, SIN3. SIN3 is the true precursor, and here you get infection right up at abnormalities in the upper layer of the epithelium. And then with secondary genetic changes, then one sees neoplasia and then invasion. So in a sense, there's no viremia. It's very, very different to any other infection we see. Now, I'll see if I can get back. I had a little bit of trouble with the video, so I had a backup slide, so we don't need that now. Thank you. So again, if we look across the board, if in different cancer types, with the squamous cell carcinomas, adenocarcinomas of the cervix, around 100% infection with HPV. Other anogenital, and here I'm talking about anal cancer, it's about 85% are caused by HPV, and here it's a difference in the typing. It's largely 16, but you can see some head and neck as well. This is basically base of tongue and tonsil, and again there's a preponderance of 16. Also a proportion of vulva and vagina in younger women. So to come to the virus, and I mentioned this earlier, when the L1 protein was put into yeast cells, just as you do with hepatitis B vaccine, you take the surface antigen, put it into a yeast cell, Baker's yeast. The L1 forms a pentamer, and as you can see there, they all self-assemble and make this non-infectious, but HPV viral-like particle. That pretty much tricks the immune system into, when the vaccine is put intramuscularly, to make type-specific antibodies. So they're largely type-specific, little bit of cross-reactivity with the viral types that are phylogenetically related. But there's no DNA, no oncogenic genes in this, they're non-infectious. So what do we have in the way of licensed vaccines? And remember, this all happened around 2007. Gardasil, which is the Merck vaccine, the 6, 11, 16 and 18, and they were chosen because of what I just mentioned to you. These should have protected against genital warts, or the majority of them, and cancers. And Cervical, which is the GSK vaccine, 16 and 18, and you can see there's some differences in the adjuvants they used and also the expression system. And then, of course, what has come along is Gardasil 9, which has the next 5 commonest types covered, 31, 33, 45, 52 and 58. And I've put down here the regimen that was used for vaccination. When we first started the vaccine trials, it was 0, 2 and 6 or 0, 1 and 6. Now we've found that in fact 2 doses in those under 15 years of age, as long as you have a gap of 6 months, works just as well in terms of non-inferiority of the vaccine antibody response. And what we found in the vaccine trials, and we at the Women's did some of these trials with both the bivalent and the quadrivalent, you can see there really very high efficacy, in the high 90s, so amazingly high, and very well tolerated. And you can see in terms of the 16-18 related disease, in those who were previously non-immune or non-affected, had efficacy. Note there's no therapeutic effect. They're purely prophylactic vaccines. And so people have argued, well, how do they work? If you're giving a vaccine in an arm intramuscularly, how are you getting a response that prevents infection at the genital tract? And how it's thought to be is, as we mentioned before, you get microtrauma, the virus comes down here and infects, but you get some exudate from the microtrauma in those who've been vaccinated, but you also get transudate from the serum, and very, very high levels, way higher than what you see, like hundreds of fold more than what you get from natural infection. So this correlates with how the vaccines work. That's how we think they work. Now, to give you that background and then to sort of really move forward, the Director General of WHO, Dr. Tedros, May last year, actually said, well, hey, we've got the tools. Why aren't we using these tools right around the world and trying to reduce cervix cancer? And that became his sort of raison d'etre, if you like. And there's been a lot of activity in WHO to really look at elimination. I'm actually on the HPV advisory to SAGE at WHO, so there's been a lot of discussion about, well, what do we mean by all of this? Now, and I start off just to show you, if you remember the graph, the figure before showing you incidence and mortality, well, this is pretty much a reversal when you look at those countries that have got a national immunisation program. So there's a lot of work to do, and really there's a lot of work to do in those countries that have got the highest burden of disease. This is the latest figure I had shared with me from PATH, showing now that there are demonstration projects happening, and in fact some countries as we speak are rolling out HPV vaccine, but it's a huge job. It is a global initiative, and I've put up here some of the groups that are really wedded to this. The United Nations Joint Program with all those bodies there as listed, various American Cancer Society, ASCO, And I have to mention International Papillomavirus Society, and certainly for HPV Awareness Day, which was March the 4th, or is every year, we certainly put out a statement, and this was to be in conjunction with that which WHO had done. And again, a call to action. You know, this is the group of scientists and clinicians who are working on HPV-related cancers and really endorsing what WHO has said. And I'll just go through some of the points made, because I think it sums up just how common cervix cancer is when you consider every 2 minutes a woman dies from it. We know it's caused by a virus, and we know that the vaccines in phase 3 trials are very effective. And in fact, now we're virtually into 10 years later, looking at data to show vaccine effectiveness. They're safe and effective. And as well as that, we now have better tests for screening. And I'm sure all the women in the audience will know that we've moved from pap smears in Australia to HPV DNA because it's more objective and it's more sensitive. And the data I'll show you in a moment is that the positive predictive value of a pap smear is going to be lower and lower as we clear disease. So, but to do this, we really have to have high coverage of screening, whatever it is, and high coverage of vaccination. And as well, we obviously need treatment of women who already are infected and have lesions. And that's a real challenge in many countries. So basically, these are obvious statements, but you know, it's going to be a challenge to work upon. So at the SAGE HPV meeting I attended, there was a lot of discussion about, well, what do we mean by elimination? This is not smallpox, this is not measles. What would be an appropriate elimination target? And if you're looking at, you know, per 100,000 women, should this be 10? Should it be 4 or 1? And in fact, for Australia, if we said 10, we'd be already there. So, and if you look at these figures here, you know, some countries at 43 per 100,000. So, you know, there's a massive challenge. So, if we don't do anything, though, and these are predictions that IARC have made. I mentioned before, it's, you know, 500,000 cases. If we don't do anything, it's going to increase to 710,000 cases by 2030. That's not that far off. And by 2040, mortality will be 50% greater. And we know that really the burden of disease is in the low-income countries. In fact, this is the recent publication showing in Nordic countries, if you see the red dotted line to the black line, how with screening alone, that has had a huge impact. So what are the tools we need? Well, I think I said it before. We need vaccines, we need high coverage, we need screening with more sensitive assays, and we need treatment of the screen-positive women. And WHO was trying to set goals here. They wanted to have 90% vaccine coverage. Now, I think that's going to be pretty hard to achieve in most countries. We in Australia haven't reached 90%. And you can see some of the goals here. In low-income countries, very few have really got a national program. To then get to 90% target is a big ask. And then, so we agreed on 80%, at least 80%, and the same, at least 70% for cervical screening. Remember, even in our PAP program for 3 yearly PAPs, it was around 65% achieved in Australia. So to get to 70 or 80 would be really quite difficult, although with newer assays and self-collected sampling, that should make it a lot easier. And if we're thinking about, you know, vaccine coverage, we do need high rates, and school-based really works better. This is sort of global data looking at those that have primary care screening, vaccination, or school-based or mixed. And school-based, it's not rocket science. WHO then said, well, okay, should we be vaccinating girls? Should we be vaccinating girls and boys? I think if we could get the vaccine down to 10 cents a pop, as we did with hepatitis B, it would certainly destigmatise this as a girl problem. And I think it has really put off some countries because they feel that we may be sterilising their girls. But because there's also a shortage of vaccine, the target is really girls, and preferably multi-age cohort, so 9 to 14 years of age, or if there's still a supply issue, single cohort, so that'll be around 10, 11, 12. So, and I think what has changed from Australia rolling out the vaccine is now we have a 2-dose schedule. I think what's interesting for the future is, would 1 dose work? And there is some promising observational data, but I think WHO was not prepared to go down that path. I personally felt, why not give 1 dose, and then as long as you can go back to those girls, if you really need 2 doses, then give it to them, because the gap, as long as it's not too short, it will work. But I think they're reasonably conservative and felt that we should stick with the 2-dose. But there are randomised controlled trials, and we await that data. And then obviously key indicators that need to be looked at is, well, if you have a national program, when did you start? What's your coverage? And then how are you really going to measure outcome? And a lot of people wanted to look at cancer registries. That's ideal in the long term, but it's going to take several generations to get that data. So we felt really to look at genoprevalence of 16-18 in the community would certainly be a way to go, but it requires good surveillance. So I'm going to give you an example now of the Australian scene, and many of you will know this, but we started off in Australia with a good news story about cancer. So it was really targeting the general public about cancer prevention. And that was in 2007. Remember, we had a catch-up program up to 26 years of age to the end of 2009. We chose a school-based program and catch-up through general practice or in the community. And then Australia elected to go down the path of gender neutralisation approach in 2013. So the boy program, very much like the girls, but not as big a catch-up program. And then as of last year, we moved across from the 3-dose quadrivalent vaccine to the nonavalent vaccine. So now we have the 9-valent and as a 2-dose, and there's a catch-up to 19 years of age. So in terms of where we're up to, I think this is important for a lot of other countries that haven't started. How you communicate about the vaccine program is really important. I know when I started doing HPV vaccine trials, people didn't know what HPV was. They'd mix it up with SV, HIV, HBV. So education, and I'm talking not just the general public, but clinicians, really people didn't know much about HPV. There was a big campaign to educate nurse vaccinators, and they're all registered and that was important because in some countries they used nurses who didn't know much about the virus, couldn't answer questions, and when people fainted, then people thought there was a problem with the vaccine. In Australia, as you know, we had a vaccine register, which is now becoming an all-of-life vaccine register, but this really helped us put together a lot of the data that I'm going to show you. And in fact, we had the ability to link the cytology registers with the cancer registers and the vaccine register. It might sound like an obvious thing, but in some countries have the registers, but the IT programs couldn't talk to one another. So they haven't been able to get that data out. They've had to do specific research projects. And in fact, a lot of the surveillance that's happened in Australia has come from research projects, and my team have certainly contributed to a lot of those. And in fact, through the cDNA group, HPV surveillance plan was first published. I think that says 2013. There's a new one being updated, although it's been slow to come. And it's to really look at things such as coverage, vaccine safety. Are there any red flags there? Genoprevalence, and then looking at the various endpoints that I mentioned, like genital warts, SIN3, and ultimately cancers. So this slide really summarises very beautifully where we are in Australia, remembering 2007 is when we started, the 4-valent. It was school-based. Then you can see where the boys started, and we had a catch-up program for a couple of years. So you can see we're up to now 38 years of age, a vaccine-eligible age group. Oops, and I think that's why, in a sense, we have a lot of data now, because the catch-up program, no one expected would be embraced so well. So in fact, what we've got is actually, high coverage, and in fact coverage going up. So this is from the registry data, and you can see in the high mid-80s for dose 1, then dose 2, dose 3. So we're doing reasonably well. We could obviously do better, but that's where we are. And in the catch-up program, we had up to 60% had one dose. So this is some data taken out by my team. So Dorothy Matchelek led the surveillance with Hannah Schilling. And you can see what we did do way back, because I'm old enough to remember the hepatitis B story, when we kept saying to the government, vaccinate every newborn. And that took 20 years to happen. So we went out and did this genoprevalence to see, well, what is the rate in the general community, because we didn't have any idea. And you can see here, this is data that is pre-vaccine for the HPV types that were being covered by the vaccine. And as you can see here, 15%, a huge drop in that to the vaccinated group. This is now 9 years after vaccination. We keep doing this every so many years, and you can see, very nice reduction, largely driven by the 16-18 in the vaccine. So a big reduction. And as we're looking at 18 to 35-year-olds, if you split this into the younger age strata, you'll see fewer people who will have prevalent infection. Median age of sexual debut in Australia is 16, so 92% relative reduction. So really dramatic effect. And in fact, if you looked at the unvaccinated in the post-vaccine cohort, you'll actually see, compared to pre-vaccine, a reduction as well, and that's herd protection. The problem is, if they go outside the herd into another population, and Australian young people love travelling, so then they're not protected. So not a good reason not to have the vaccine. And in fact, we've found herd protection in males, and you can see here in these colours, these are the 6, 11, 16, 18, and you can see in the younger males, this is not from vaccinating young boys, because that was only for a few years, was a catch-up. This is the effect of the girl program on the boys. So what do I mean by that? Think of this is, remember, an infectious disease. Most people get infected. Some get disease, some will get neoplasia, but you vaccinate, you shrink down that infection, so you'll get less disease, less cancer. So that's a simple way of putting it. It's just that this takes much more time than most other infectious diseases. So what about the clinical diseases now. And I said to you before, genital warts have a very short incubation period, and this is what we saw very, very early. This is when vaccination happened, a massive drop in the young ones, this is under 21, with genital warts. And I used to work in the Melbourne Sexual Health Clinic. We used to see so much in the way of genital warts. Now they hardly see any cases, which is fantastic. And this happened, as I said, dramatically and quickly in the females and again in males. So the next disease with the next longest incubation period is the cervical abnormalities, histologically proven. And here you can see with time the declines in those now up to 30 years of age. So this is the precancers are being prevented. And we haven't seen the Australian data yet in young women, and I think back to Yasmin's PhD, and we have all the baseline data on women up to 30 years of age. It's an uncommon disease, but I would have thought we should be able to see a reduction. And some other countries, such as the Finns, the Scottish, and the US, have shown, even the US, where the coverage of the vaccine is not very good. In the younger women, they're seeing a reduction. The Scottish data is probably the best. It's not published, but in 20 to 24-year-olds, it went something in the order of 15 cases per year, now to 1 case per year. So I think that's pretty tight. And for the non-believers that we can't get cancer reduced, there it is. So having told you that, what are the challenges? In fact, I probably should update this. It's a relatively new vaccine, but hey, it's been with us now 10 years. But because it takes such a long time to get the disease, I think one has to be patient in trying to get people understanding how these vaccines can work. So education's very important. It becomes really important because in some countries, I think Australia's done well, but the US, some parents were against the vaccine because they thought it would increase promiscuity. There's no data at all to show that. It's like teaching kids about safe sex. It's better that they're armed with the knowledge. It certainly needs government investment, and if a country doesn't really support vaccination, there are problems. And an example of a sophisticated society where the government initially rolled out HPV vaccine was Japan. They had some bad press. It wasn't dealt with quickly, and I think this is where I think you need to have key opinion leaders who can get in quickly, and the Ministry of Health say this is safe and okay to do. They have now, 4 years later, have zero population being vaccinated, whereas previously they were 70%. And interestingly, because screening is not well embraced either, they're seeing more cancers in young women. So, it might sound a simple thing to do. And I mentioned before availability of the vaccines. I described the viral-like particle manufacture. I gather it takes 4 years to make a batch. So there's a big drive now to try and have more manufactured. And I know, for example, India, the Serum Institute is also in phase 3 trials. So maybe eventually we will see HPV being a bit like HPV, being very cheap. And again, just to come back to the Australian data, I mentioned before that we have had a good PAP screening program, and it really only worked when it was organised. And I think this is why in poorer countries it's so difficult to get the rate down. And even you can see here, pre-organisation, we were not doing very well in Australia. It takes a lot of quality assurance and control and a lot of screens to really have an effect because it's a low sensitive test. And in fact, you can see here we were just around 8, and around 2 in terms of mortality. This is incidence. But because of the data I showed you before with the SYN3, Australia's moved across to the more sensitive testing of HPV nucleic acid testing. So to come to the modelling, and this was published only at the end of last year. You can see this is incidence data, this is mortality data. So I guess modelling is as good as the data you put into it. And this is data that Karen Canfill's group in Cancer Council in New South Wales published. And you can see here, this is using the 9-valent vaccine and predicting incidence. And this is if you actually stopped actually screening with HPV DNA, because with the vaccine you can see you're going to get marked reductions. So initially you're going to find more, so then people will say, oh, the vaccine is not working. But actually this is just because it's more sensitive. In that initial year you will find more. What they predict with their modelling, so here we are, remember WHO said 4 per 100,000. So in fact, by 2030, we should be at that rate. And in mortality, this will take longer to get to 1 per 100,000 around 2040. So that's working on these base estimates the WHO has said. And that, of course, means we have to continue our screening and our vaccination, at least as where we are. So we do have to be wary of anti-vaxxers and the like who could disrupt the program. Australia has had issues during rollout, but I think it's really been handled very well with the Ministry of Health coming in, key opinion leaders, etc., and continued with great rates. So sort of to finish off, what do we need in terms of research requirements for anyone who's out there thinking to work on HPV? We need more data on single-dose vaccination. I think whilst we say we can give 2 doses up to 15, it'd be nice to think we had data. I mean, what's special about 15? It was a bit like what was special about 25. And until someone did the studies up to 45. So I think, that's something which would save a lot of doses around the world. What about those with chronic disease, those with HIV? These studies, there are some small studies in HIV-positive children. You get good immune responses, and, do you need to have 3 doses rather than 2? That's what the guidelines are, but we don't have any 2-dose data. And then really what we want to see is effectiveness in not only cervix, but what about anal cancer, vulval cancer, the tonsillar cancers. So that's right, I said I would talk a little bit about a study that we're doing. It's an MRC-funded, Newton Foundation grant, a consortium of people from MCRI, India, UK, School of Hygiene and Tropical Medicine, University of Melbourne and the Women's. And basically, this is to look at 2 countries that really have almost 40% of the cases globally. And there, it's the second cancer of women. And having visited the sites for where these studies are going to be, and in fact in Ethiopia, they had a demonstration project of vaccination in 2015. So we will have that group plus a control group to look at what's the impact of the vaccine from back then. And whilst we visited there, going to some of the local hospitals, there's no radiation therapy. The women basically come in to die, and they still don't get admitted. They get some morphine to go home with. Some countries don't even have the morphine. It's a pretty awful disease. Women who still have families to rear, and yet, really preventable in large part. So we chose these 2 countries. to be involved in this project where we want to look at education, rollout of vaccine, etc. And I have to say, when we were in Ethiopia, and this is a very poor country, having seen all these women with disease, and then visiting the ministry, they said, "Oh, we're going to vaccinate. We'll do that in November." And I thought, really? And I was very pleased to hear that in December, out of 1.4 million young girls they were targeting, they had already vaccinated 1.1. So where there's a will, there's a way. And Dr. Tedros from WHO is Ethiopian, so whether that has anything to do with it or maybe it's just the Ethiopian spirit. So there you go. It can be done. And in India is just starting now up the north. I guess they've had a few other issues. Oh, yes, I think my husband actually found this and gave it to me last week. He said to me, with all of that anti-vax problems, some of you may have seen this in the newspaper, this young boy of 18, his mum is an anti-vaxxer. So none of these children have had any vaccines, and he did his own research, looked at the CDC website, etc., and in fact was invited to speak at Congress, the Senate Congress, last week to say why he believed in vaccination. So I thought a few more advocates like that is what we need. So to finish, I think I can say to you that we should see elimination of cervix cancer within our lifetime, or at least in Australia. We have the tools to do it. Modelling predicts the findings to date, and there's certainly a lot of political will at WHO, and now I think it's really all the countries rolling out the vaccine and screening and treatment, and remembering that it's not just about women, it's about men and women and other HPV-related diseases. I think I left out, I meant to say to you that one of the other rather rare but awful diseases to treat is recurrent respiratory papillomatosis. Basically, it's warts in the throat and down to the lungs, and it has significant morbidity and mortality. And because we had data pre-vaccination in the juvenile onset type, and remembering that the mothers who are now delivering are at that age where we should see a reduction. Last year we did publish as a collective, with ENT pediatric surgeons, RRP has dropped significantly as well. So another, good news story. So I think it's a nice story, but we've got lots of work to do. And my team are actually doing a lot of the surveillance for the Commonwealth on looking at the genotyping reduction, but also looking in cancers using laser microdissection. And we've got a baseline in terms of what our viral attribution of lesions is as causes. And then we can look going forward, what's the impact of the 9-valent vaccine, and then, what's the impact on the cancers. So maybe I should finish there. Yes.
Thank you so much, Suzanne, for that absolutely inspiring presentation. We're happy to take any questions from the floor now.
Is the protective effect only due to the antibodies, or are there T-cell effects as well?
Good question. There's not been a lot of work done on T and B cell effects. It's largely neutralising antibodies that correlate with the protection. There's probably some T-cell interaction because there's some cross-reactivity of phylogenetically related types. So, for example, 16 and 31, 18 and 45. But there's very little data, actually. Some have done some avidity and affinity assays on antibodies, but in terms of T-cell, it's quite difficult. Many years ago, we tried to look at the cervical secretions and looking at antibodies in that, or T-cell reactivity. But you've virtually got to be sure that you've collected just secretions and not abrading the epithelium and picking up the systemic reaction. But I think, again, that's something that should be studied.
I have a question. I was really interested in the slide that you put up of the teen who, whose mum was an anti-vaxxer and got himself vaccinated. Is there any recourse for adults who actually didn't have the vaccine when they were children because of that decision by their parents?
Yes, I mean, I guess it's a legal question in a sense, and when I've been in Japan, I have raised that. I might get shot by the anti-vaxxers, but, you know, perhaps someone who had a refusal and who later ends up with disease, you know, could turn around and, I guess, sue their parents, or maybe sue the government in Japan because they haven't promoted vaccination. But it's an interesting scenario, and I don't have a legal degree.
In cultures that practice circumcision, is there any perceived advantage?
Yes. Again, one of my Spanish colleagues actually looked at that, and circumcision is protective against HPV transmission and cancer, however that works. Maybe that's about viral load in the male and transmission to the female. But yes, so another good reason for circumcision.
I have another question actually about the antibody levels with the non-valent vaccine and what it looks like. Is it very similar to what we see with Gardasil 4?
Yeah, I mean, because the immunity is largely type specific, people kept thinking about putting more and more viral or VLPs in the vaccine, but it caused interference between viral types. So, but with the 9-valent, that's certainly been measured, and you get much the same pattern as you do in the quadrivalent. I mean, interestingly, if you take a cohort that have had the quadrivalent vaccine and then give them the 9-valent vaccine, the effect you get is more in the 6, 11, 16, 18 than a naive population, but a similar 31, 33, 45, 52, 58. And that's a bit analogous to the scenario in flu. You know, with, I think Sir Macfarlane Burnet proposed the theory of original antigenic sin. So the virus to which you were first infected with is the one that you then boost your immune response to. That's exactly what we showed in the group who had the 4-valent earlier and then had the 9-valent. But we don't. One thing I should have said is we don't have an immune correlative protection. I mean, the antibody levels that are induced by vaccination are really, really high, but there's been no breakthrough disease or breakthrough infection. So you can't say above and below a certain level you're protected or you'll get disease, as you do for, say, rubella. And I think it's thought that you probably don't need much of a titer at all. The neutralising antibodies have a very high avidity and affinity. There's some complex sort of crystallography work that has shown that. So there's strong binding, and maybe we don't need the titers that we need. But I think as medical graduates, we were always had, for a vaccine, it's a titer that you look at, but we don't have one in HPV as yet. And there's a lot of surveillance to look at that. Even in the original vaccine trials, which started well before public health programs. So in Scandinavia, where people have their unique identifying number, basically they're being followed through. So they're now at about 15 years post-vaccine, and there's no breakthrough at all, which is great.
If there's no more questions, then I'll close this session. Thank you so much, Suzanne, for such an amazing presentation. Please accept this as a small token of our appreciation.
Thank you.
And if I think back to being a gynae oncology resident now, looking at elimination, it's absolutely unbelievable. So it's wonderful to actually experience that.
Thank you.